Hello, and welcome to ACR Journals on Air podcast. I'm your host, Vicky Shanmugam. Before we begin, I'd like to thank Bharat Kumar for generously serving as guest host over the past few episodes again. I'm very grateful to him for stepping up to the microphone at very short notice, and all of his efforts are much appreciated. And now, on to today's episode. Many chronic inflammatory diseases affect women during their childbearing years. Currently, about 22% of those with conditions such as rheumatoid arthritis, psoriatic arthritis, or inflammatory bowel disease are prescribed a TNF inhibitor while they are pregnant. Because these drugs cause an increased risk of serious infections in non-pregnant people, it's reasonable to assume that there may be an even higher risk during pregnancy. But is this risk real? What does the data show? In the manuscript we will discuss today, tumor necrosis factor inhibitors and risk of serious infections in pregnant women with chronic inflammatory diseases, published in ACR Open Rheumatology, we are about to find out. A link to the manuscript and disclosures can be found in our show notes from today, and I'm thrilled to be joined today by the senior author of this manuscript, Dr. Evelyne Vinet. Dr. Vinet is an associate professor in the divisions of clinical epidemiology, experimental medicine, and rheumatology within the division or Department of Medicine at McGill University in Canada. She established the world's largest cohort of offspring born to women with systemic lupus erythematosus, and she's uncovering novel associations with increased risks of congenital heart defects, stillbirth, and autism spectrum disorders. Building on this work, she is now leading the creation of an international cohort of lupus pregnancies and conducting a randomized controlled trial aimed at improving knowledge of preeclampsia and adherence to aspirin therapy among pregnant women with lupus. Welcome to the show, Evelyne.
Thank you, Vicky, for inviting me. It's a pleasure to be here to discuss our study today. Thank you.
I wanted to begin with actually a huge thank you to you for doing this research. Management of rheumatic diseases during pregnancy is always challenging, and it's fabulous to have some good data to help guide us. So to get us started, can you share with our listeners the story behind this research? Why was it important from your point of view to do this study?
Yes, because we know that TNF inhibitors have an immunosuppressive effect outside of pregnancy. And during pregnancy, there's a state of naturally reduced immune response. And we didn't know until now about really the risk of infection in pregnant women exposed to TNF inhibitors because they are pregnant women commonly excluded from TNF inhibitor clinical trials. And the largest studies on serious infection in women exposed to TNF inhibitor with chronic inflammatory disease had been conducted based on observational and population-based study, but they were limited because they were of a smaller sample size. They excluded women who were postpartum, and it's important to look at serious infection in the postpartum, as well as they look at TNF inhibitors as a fixed exposure and not time varying because women might stop their TNF inhibitor during pregnancy. So this was important to do this study.
So tell us about the MarketScan database that you used to conduct this research. What is MarketScan, and how did you as a researcher obtain access to the data?
Yes, so MarketScan is a United States health insurance claims database, and it contains de-identified medical and drug claims for more than 270 million individuals that work through large companies that are insured commercially, and this includes the employees, but also their spouses and their dependents, and this will include data on physician office visit as well as hospitalization and drug prescription. And the medical diagnosis and procedures are recorded within MarketScan using international classification of disease codes as well as procedure codes, so we can track down disease and condition as well as medication. And we had access to a MarketScan through a partnership with the University of Alabama in Birmingham.
And so from this very, very large data set, you selected several cohorts to study. Tell us about those cohorts. In particular, how did you figure out whether someone was pregnant, and how did you confirm the presence of an inflammatory disease?
Yes, so we selected all women between the age of 15 and 45 years old, so reproductive years, and who had a primary diagnosis related to pregnancy within hospital diagnostic codes. And this could include women who were hospitalized for births, so this could include live births or stillbirth, but also other pregnancy outcome, for instance, spontaneous or induced abortions, as well as ectopic pregnancy. And this was done between 2011 and 2021. And then for the postpartum analysis, we excluded the pregnancies that did not end in a birth. So we excluded spontaneous and induced abortions, for instance. And then to make sure that we were studying a patient with chronic inflammatory disease, we required that pregnant women had a diagnosis based on diagnostic code of RA, ankylosing spondylitis, psoriatic arthritis, or psoriasis, or inflammatory bowel disease before the onset of pregnancy. And then we use 4 categories based on a hierarchical definition, where if a woman had a diagnosis of any IBD code, for instance, she was classified as having IBD. But then if she had a diagnosis of RA within the diagnostic code, but no IBD, then she was classified as having RA, even if she could have had other diagnosis, but not IBD. And then we went on like this for psoriatic arthritis, so they shouldn't have IBD or rheumatoid arthritis, but then this was, they were diagnosed as psoriatic arthritis. And then the 4th category included those that had any ankylosing spondylitis or psoriasis code, but not the other diagnostic code that I mentioned, because sometimes in administrative database, we can see that one patient might have more than one diagnostic code, depending how a rheumatologist might label a patient with psoriatic arthritis versus a dermatologist might label a patient as psoriasis. So it was important to do that hierarchical definition to really classify those women.
It happens all the time. So what criteria did you use to determine TNF inhibitor exposure? And can you share with our listeners, how did you make sure people who switched therapy or who stopped their TNF therapy because they'd become pregnant were evaluated?
Yes, so we defined TNF exposure based on at least one filled prescription or at least one infusion procedure for the TNF inhibitors that are given by infusion. And to make sure that we were capturing those that switched therapy or stopped during pregnancy, we use a time-varying exposure definition. So we assign each person day of follow-up based on if a patient was taking a TNF inhibitor and based on the subtype as well of TNF inhibitor, but very few switch from one TNF inhibitor to another one. And also we assign a grace period of 5 half-lives. So even if a woman stopped, for instance, in the first trimester TNF inhibitor, she's still exposed to some extent in the following weeks because it has a long half-life. So based on the different type of TNF inhibitor, we added 5 half-lives to make sure that we covered that. And also, if one switched from one TNF, then we captured the exposure to the other TNF inhibitors.
Great. So that's the way to do it. Thank you for explaining that. So your outcomes were serious infections. How did you define infection in this cohort?
So we use ICD-9 or 10 codes to identify infection, but we required it to be on a primary hospital discharge diagnosis. So that code needed to be the primary reason for hospitalization, so that this ensured that it was not just like a secondary diagnosis during an hospitalization. And we only counted the first occurrence primary hospital discharge diagnosis of infection during pregnancy or up to 90 days after birth in the postpartum period. So, and this was based on prior study that used a similar approach.
And how comfortable were you using the coding data? So ICD-9 and ICD-10 coding, we know, has some limitations. How good is it as a surrogate for the diagnosis of infection, the diagnosis of inflammatory disease, and indeed other pregnancy outcomes?
Yes. So as I mentioned, for infection, we use ICD-10 diagnostic codes, for instance, that have been validated against manual chart review and were found to have a very good positive predictive value of 80%. For the ICD-9 period, because in MarketScan, they use ICD-9 over a certain period and then they switch to ICD-10, we use also infection-related hospitalization, but those might not have been validated, but they have been used in prior population-based course study with very result that made sense. And also for the chronic inflammatory diagnosis, we use previously validated algorithm that that could have changed a bit based on the different diagnosis. So in that way, we make sure that we try to use as much as possible validated definition to minimize misclassification, because it's not because you have a diagnostic code, we know that you necessarily have the disease. But when we use different algorithms that have been validated against a chart, we are more confident that this is the case.
You looked also at a couple of different confounding variables because obviously other factors play into the risk of infection. Can you tell us about the confounders you included in your analysis?
For this study, we look at different comorbidities that were at any time before the onset of gestation. For instance, we look at age, pregestational diabetes, and asthma, as well as we use pregestational use of systemic glucocorticoid and non-biologic immunomodulator in the 3 months before the onset of gestation. And then for the postpartum analysis, we also included the gestational drug use, like glucocorticoid and immunomodulator during pregnancy, based on at least one prescription filled during the pregnancy. And also we look at gestational diabetes and infection during pregnancy in the postpartum analysis. Also, we use a surrogate marker for disease severity because we don't have a perfect measure of disease severity in administrative database. So we use the number of chronic inflammatory disease specialist visits that the patient had in the 3 months before pregnancy, as well as hospitalization. And also, we accounted for the type of chronic inflammatory disease because someone with inflammatory bowel disease likely have a more severe disease than someone with only psoriasis, for instance, cutaneous disease.
Interesting. There's many variables that go into the number of visits to a rheumatologist, including how worried the rheumatologist is about the patient and their pregnancy. So when you did your analysis, did you clump all your inflammatory diseases together or did you analyze them separately? Tell us a little bit about that.
So because we adjusted for the type of chronic inflammatory disease, in a way, we did not clump all of them together, though when we look at the risk of TNF inhibitor overall, this is across the different chronic inflammatory disease. We were able to assess both ways in a certain sense.
So a little bit of both. So how many patients were in the cohorts that you analyzed? How many births did that equate to? And I guess more importantly, how many of those pregnancies were exposed to a TNF inhibitor?
So a total of slightly more than 70,000 pregnancy in about 62,000 women met the inclusion criteria. And this corresponded to almost 70,000 births, so 69,412 births exactly. So overall, close to 4,500 women received at least one prescription for TNF inhibitor during pregnancy. And so in the postpartum, a total of slightly more than 3,500 pregnant women went onto the postpartum and were exposed to a TNF inhibitor during pregnancy. So this gives roughly the number. So overall, 4,500 almost were exposed to TNF inhibitor during pregnancy and slightly more than 3,500 in the postpartum period.
Great. And so walk us through the results. You have a set of Kaplan-Meier curves in figure 1. And here you're using survival as being the survival probability free of infection. Describe those curves for our listeners. What did you find?
So as you mentioned, the two panels show the Kaplan-Meier survival curves for each exposure group. Like in panel A, it's pregnancy, and in panel B, it's postpartum. And so this illustrates, as you said, the cumulative survival probability free of serious infection. So if the curve was flat, actually, this would mean that no one would have gotten an infection. And each time there's a drop, like a step in the stair, for instance, it means that there's some events of infection occurring. And we see that the group exposed to TNF inhibitors have more infection because as we can see, the curve is lower, like go down more rapidly in a sense. But we need to be mindful that the y-axis is scaled to display a range that appears a bit bigger, but actually it's from 98.5% to 100 because there was no survival probability that dropped below that threshold. And this was really to highlight the difference between in the upper range of those two exposure groups. And when we look at the survival analysis with Cox proportional hazard, this led in during pregnancy in a hazard of almost 40% more rate of infection in those that were exposed to TNF inhibitors compared to unexposed. And then in the postpartum, this led to a hazard ratio of a bit more than 20% more of rate of infection. But both confidence interval included the null. So, but possibly for the pregnancy, this might have been because even if we had a lot of patients included in the study, we might have been a bit underpowered because the confidence interval was close to the null from 0.95 to 2. So there was a trend for potentially an increase in serious infection in pregnancy, for instance.
You conducted some secondary analysis to ensure that your follow-up time was appropriate for the different TNF inhibitors, all of which have slightly different half-lives. Were there any differences when you took that into account?
Yeah, so we changed the grace period, for instance, to 4 half-life to see if changing this could change the effect estimate. So when we reduced it to 4 half-life, it did not change the estimate drastically. Actually, it made the hazard ratio at 1.49, so almost 50% more rate of infection. And it actually included the null value. So, but the confidence interval was slightly wider. Then we reduced to 3 half-lives, but then the effect was nearly null. So this suggested that when we reduced to 3 half-lives, we might have more biologically exposed time that was classified as unexposed. So this might cause that. And then when we lengthened the exposure grace periods to 6 or 7 half-lives, then we diluted the effect further by classifying biologically unexposed time as exposed. But the effect estimate did not change substantially either. So overall, doing all that so that our results were relatively consistent with our preliminary analysis. And so we were we thought it made sense. And 5 half-lives is what we usually use to make sure that the drug is eliminated. So I think it was fair.
Yeah, I think it was fair too. So in table 3, you ran an analysis of the incident rates of serious infection by specific TNF inhibitor with the time-varying exposure during the pregnancy postpartum period. Can you explain what that analysis showed?
Yes, so this was done to make sure that there was not one TNF inhibitor in particular that was driving all the serious infection. And we saw that during pregnancy, we observed higher absolute rates of serious infection in all the different TNF inhibitors. So infliximab, adalimumab, etanercept, and certolizumab, as opposed to those unexposed. And then in the postpartum period, we had similar result, but adalimumab, had a slightly smaller incidence rate, but 95% confidence interval were non-significant. And also, like when we start looking at different sub-analysis like that, we can anticipate that we'll find results that are a bit discordant. So this might have been just because of the small numbers in those specific subgroups.
Yeah, always a challenge once you get down to the small groups. I have to ask, the timeline of your study did overlap with the beginning of the COVID pandemic. Did you see any differences in prescribing for the patients who were pregnant during that period? Was there any relationship between TNF inhibitor use and COVID infection in the limited data set that you have from that time?
Yes, so that period is very small in our cohort compared to the overall study period. It's from 2011 to 2021, actually. So we did not observe substantial difference in prescribing. But again, that period was very small. So this is really we need to be cautious when looking at this. And after January 1st, 2020, there were only 4 patients who had serious infection during pregnancy and 11 patients during the postpartum, and none of whom were associated with a hospital ICD diagnostic code corresponding to COVID-19, which were used at the time. But again, maybe we had some misclassification, but there was no fatal infection observed because no patient had an infection date that coincided with the date of death. So were reassured by that as well. So we don't think that there was actually it's very difficult because it was so a few events, so we cannot draw a firm conclusion from that.
Yeah, that's because all the patients avoided going to the hospital if they could. So this, though, is a fabulous data set, and the information you've shared is really invaluable. It's great to be able to guide our patients with some real world data. Are there any limitations of this huge data set that our listeners should be aware of?
Yes, so there's the intrinsic limitation of administrative database study. So there's always the potential for misclassification of drug use since MarketScan records the filling of prescription, which doesn't mean that the patient took the medicine. Exposure to TNF also was based on filled prescription, except for infliximab and golimumab, which were identified by infusion procedure code. So because we knew a bit more about if the patient took that medicine through the procedure code for infliximab and golimumab, then we might have had a more accurate exposure assessment for those 2 TNF inhibitors who probably were more likely to be given in patients with more severe disease. So this could have led to more infection in those. So this could be something that could have led to our risk of infection. But again, we were able to look at the different other type of TNF inhibitors. Also, MarketScan, and like most administrative database, does not provide information on the onset of gestation. So we had to use a validated algorithm to define the onset of gestation for the duration of gestational period. So there might have been misclassification of when we said that the patient was actually pregnant or not, but we did sensitivity analysis. So we're still confident that this was not a huge concern. And also, it's possible that even if a patient was diagnosed as a serious infection through a primary discharge diagnosis, we all know that we might have a non-infectious disease that masquerades as an infection. So it doesn't mean that the patient necessarily had that infection, though usually when we get a discharge diagnosis with the primary reason for hospitalization being infection, patient has been really well investigated, and we would have had, for instance, culture that are positive. So usually it's a more accurate diagnosis. And finally, one of the limitations is that many administrative databases do not record any measure of disease activity. So there could have been residual confounding by disease severity, but we control for physician visit and hospitalization prior to the pregnancy, as well as drug exposure other than TNF inhibitor. And then there's always potential for other confounders that are not measured within the MarketScan, like body mass index and smoking, for instance. But overall, knowing the limitation of our study, we're able to get a sense of where could be the bias, and in the end, it informs us when we interpret the result. And I think it makes our study still have some strength, and it provides important information.
Yeah, I really agree. I feel this analysis was incredibly helpful, and I think helpful both to the rheumatologists and our patients. I'm intrigued by some of your other work, and I wondered if we could take a little diversion into that. I'd mentioned at the beginning of this podcast that you're studying a large cohort of lupus offspring, which is babies born to women with lupus. Can you tell us a bit more about this cohort? I'm intrigued that you've been able to study not just the short-term outcomes measurable at birth or soon after delivery, like a congenital heart defect, but also long-term outcomes like autism spectrum disorders. Tell us a bit more. How do you follow this cohort and what have you been finding?
So what we have done, and I've done that work when I was doing my PhD with my mentor, Sasha Bernatsky. So we have, what was the difference is that most of the study before that had focused on pregnancy complication during pregnancy in patients with SLE, with lupus, but we knew not a lot about the outcome of the offspring. And so we use an administrative database and Canadian administrative database because we have a universal healthcare system, which allow to link very well the offspring to the mother. So we were able to link offspring born to mothers with SLE. And so that had not really been done in lupus before that. And so we were able to see if offspring born to women with SLE had more adverse outcomes that are not just associated with pregnancy, like small for gestational age or like preterm birth, but more health outcome like congenital heart defect that might have an impact on long-term health, as well as autism spectrum disorder. So we saw that there was relatively a twofold increase in the risk of either congenital or block autism spectrum disorder. But what we need to emphasize is that the absolute risk was still very small. So we should not be too much alarmed, because even if we find a relative risk that is increased, it doesn't necessarily mean that all the children from patients with SLE will have the disorder. So the absolute risk was still very small, but it provides some information and allow to generate a hypothesis. And because also in the Canadian Universal Healthcare System, we have like long-term follow-up on the offspring, so we can follow and have like good information on those kind of conditions.
And so in this data set, you're continuing essentially to follow those patients because they continue to be followed in the Canadian healthcare system.
Yes, so usually they have like a very, we know when the follow-up is longer than, for instance, in commercial privately insured database. Yes, we have information on that, for instance, from vital statistic database as well. So it's very interesting.
That's fabulous. So very unique data set, and hope to hear more then in the future. You've also shown that children born to women with rheumatoid arthritis have an increased risk of autism spectrum disorder. And I'm intrigued, why do you think that these associations might be occurring? And is this something you're continuing to study?
So we had shown through a systematic literature review that some evidence was pointing toward an increased risk on rheumatoid arthritis. There had been some good European administrative data showing an increased risk. And this, again, similarly to lupus patient, there's the hypothesis that maybe inflammation during pregnancy might increase the risk. Autoimmunity as well has been potentially linked to autism spectrum disorder. I have more now focus on establishing a prospective cohort of lupus pregnancy, because I see in my practice lupus patient and also pregnant lupus patient. And it's great to have access to an administrative database study and do those kind of study. But I really wanted to have a cohort of the patient that we see in clinic and that are very representative of as also like SLE tertiary care center are seeing, and where we have confirmed diagnosis of SLE and good measure of disease activity. So I'm not excluding that one day I will extend to follow the offspring of that clinical cohort, but already it's a huge undertaking to have like a prospective cohort of lupus patient clinically, not using administrative database. So this might take a bit of time before I go on to the offspring for now.
Well, that would be a great study to do. So I do obviously hope that you do it. So I have to ask, what drew you to study pregnancy outcomes in rheumatic diseases?
Because rheumatic disease affect women during their childbearing years mostly, and also because the disease itself might increase the risk of pregnancy complication. I always thought it was profoundly unfair for women that are affected. Those diseases affect predominantly women, and it might complicate the pregnancy. And also, we might not remember, but a couple of decades ago, women with rheumatic disease were told not to have children, period, not even to consider that. So I thought it was really unfair, and I'm not that old, but like when I started to practice, it was still in some rheumatologists were still saying that to women that should not have been told that, because their disease, I know, like it's extremely rare that you have a contraindication to have a pregnancy. So I thought it was like that component, and being a female as well, it resonated a lot to me, that unfairness.
Yeah, well, I'm really glad that you're doing this work, and I'm sure that lots of women around the world are very glad that you're doing this work. You've been very successful academically. You've had tons of publications in this area, but this work doesn't happen alone. And when you're studying rare complications of rare diseases, there's always a big strength in numbers. Do you have any tips for our listeners on how to forge productive collaborations, particularly international collaborations?
So the tip that I have is first I've been privileged because I have a strong mentorship. My mentor, Sasha Bernetsky, had been mentored as well by the great mentor Anne Clark, who also mentored me. So I've been very lucky. And this also teach me that it's very important to do mentorship and to collaborate. And I'm privileged because the Canadian rheumatology academic community is very keen on collaborating. So we have like pan-Canadian like group of research in all the different disease, and I've been lucky to be part of the lupus community, the Canadian lupus community, and also this gave me access to the international lupus community with the SLIC group, the Systemic Lupus International Collaborating Clinic group. So I've been very privileged to be part of that group, and my mentors have shown me that we need to connect, we need to a partnership. We cannot do anything in silos, and to say yes to opportunities and to try to help people when they need our collaboration, and then not to be afraid also to ask when we need to have someone with the expertise that we don't have to do research. So that's what I would suggest to young trainee, to not hesitate to network and to connect with others as well.
And looking back, what pivotal experiences or decisions most shaped your career path in science and medicine? Do you have any guidance for other young researchers who aspire to make similarly impactful contributions to autoimmune disease and women's health?
Yeah, to have great role models is one thing that impacted me as well. Both were two great female researchers, so for sure it had a profound impact of me. I think this and the other guidance they showed me is not to be discouraged by adversity, and if we're said no to continue, if what we are doing makes sense. And also, I have to say that as a female, I don't want to only focus on that like gender, sex angle, but I think it's playing out today. But I've been told as a woman, and we hear that less maybe, but sometimes it comes back, depending on the period, that it would be hard for me to have a family, that I should, if I wanted to do research, it would be very difficult. So I kind of get the sense that it was not really welcome for a female who wanted to have a family. But again, I thought it was unfair. So, and when I was welcome in a research environment where I had two great role models that were females, that just really motivated me to do research in a field that could allow women with that are maybe not able to have a pregnancy, or were not told they could not have a pregnancy, can have a pregnancy and a family. So this was kind of a way for me to, and I thought it was very interesting.
Yeah, no, it sounds like you really found your purpose and you're a role model in the field. So, Evelyne, I really want to thank you for sharing your science and your life experience with us today. It's truly been an absolute pleasure to meet you and learn more about your work. And I just want to thank you for coming on the show.
Yes, and thank you. And I really also want to mention the incredible work of Leah Flatman with the PhD that is the first author on the paper. This work would not have been possible without her work. So we learn a lot from our trainee as well. So this is, you asked what I could say to trainee, but I learned so much from trainees. So it goes in all the directions. So thank you for having me today. It was a pleasure.
Oh, thank you. I want to close today by also thanking all our patients living with autoimmune diseases. Your courage makes studies like this possible and reminds us of the power of collective real-world data to shape better care and guide clinical decision-making for those who follow. Thank you for placing your trust in the scientific community and allowing your experiences to inform the future of healthcare. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Rheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.
This podcast was edited by Resonate Recordings.